point, I was suggesting.
Yeah, probably be easier just to do that.
Check and make sure that it's responding. There we go. Okay.
Okay.
Great.
Faculty who are usually here have departed for other commitments.
Not a problem, like lunch.
Well, they've been provided lunch, which they ate in the last half hour.
Okay. Well, no challenges. So it's not it is certainly nowhere near a full hour talk. So.
I guess I'll let you introduce yourself. I could say.
No, I'm perfectly fine.
All right. Let's see what's going on out here.
Just give me the high sign when it's time to start.
Talking about Wendy's screen. Is it a play on the choosing wisely?
Yes,
wisely
yes,
guidelines?
yes.
Got it. How to choose wisely.
Are we ready?
Maybe, well, I'll do a little introduction.
Okay, go right ahead.
Ladies and gentlemen, I think it's time to get started. I think you all know Dr. Means, who is the Dean of our medical school. Dr. Means is also an internist and a board certified hematologist. So he's going to talk to us today about hypercoagulable disorders.
Okay, thank you, Charlie. And a pleasure to be here today. So what I'm going to do today is I'm going to talk to you about hypercoagulable disorders, or thrombophilic disorders is the more current term. And when, after a venous thromboembolic event, which is what VTE stands for and includes both DVTs and PEs, when do you screen for a thrombophilic state, or basically how to choose wisely? The nature of medicine is like many other things in life, driven by fashions. And over the 30-something years that I've been practicing hematology, and pretty much all of it benign hematology, there's been a wide array in the fashions in regard to hypercoagulable or thrombophilic disorders. As a number of disorders have been defined over time, tests which were clinically available began to be developed, and the nature of a test is if it's available, people order it. And so for many, many years, anytime somebody would have a DVT or a PE, an array of thromboembolic disorder, of thrombophilic or hypercoagulable disorder tests would be ordered, which would then lead to the question of what exactly are you going to do about it when you get that result? And more particularly, what are you going to do, for example, about the patient's relatives and all this? So it is not uncommon in my previous practice, where I did a lot more business, that somebody would come and they would have had a DVT, and they would have been found to be positive for factor V Leiden as a heterozygote, and they'd ask me what they should do, and I would say, you need to finish your anticoagulation, and just watch out next time you're in a high-risk state. And what should they do about their relatives? Well, I would tell them what I'm about to show you all, and then generally in about a month, I would start to get an array of all their relatives who had been screened and wanted to know, either because their screen was negative, was there really nothing they had to worry about, or because their screen was positive, should they start anticoagulation right away, and should they use a novel anticoagulant, or should they use Coumadin? So this is a kind of a real life, ripped from the headlines issue. You're probably all familiar with the Choosing Widely campaign, which was developed by the American Board of Internal Medicine as sort of a public service, as a way of identifying routine practices which needed to either be questioned or changed. And they would engage with a variety of specialty societies. In this particular case, the American Society of Hematology, and develop some things that they thought needed changing. And I'm going to talk about two of the hematology Choosing Wisely recommendations, number 2 and number 6, and one of which relates to the use of thrombophilic disorder testing in certain circumstances, and one of which relates to the duration of anticoagulation for people in that circumstance. And I'm going to try and put it in sort of a general context of how you approach the question of thrombophilic disorders more broadly. Disclosures: I'm a member of the American Board of Internal Medicine Hematology Examination Committee. The presentation is not secret information straight from our last meeting, or even the meeting before that. The presentation cannot be reused in a formal board review course. They don't let us do that because they figured that otherwise we could all make a lot of money being in board review courses if you're on the exam committee. But in any event, I'm also a hematology consultant on a clinical trial jointly funded by NIH and Sanofi. The topic is not related to coagulation at all. And I'm the editor of a textbook published by Lippincotts, although I don't write any of the coagulation chapters for it. So what are the clinically significant thrombophilic disorders? They break down into 6 or 7 categories. First are deficiencies of the natural anticoagulants. These are protein C, protein S, and antithrombin 3. These are the best known of the major thrombophilic disorders. Fortunately, because they are also the most severe, they are relatively uncommon. Disorders that amplify coagulation by causing basically the coagulation processes once started to run a little bit longer or to be less sensitive to suppression are the prothrombin mutation and factor V Leiden, which again are specific mutations. You can also have thrombophilic disorders from vascular issues. I classify hyperhomocystinemia as a vascular issue because that is largely how it produces its manifestation. The methyl tetrahydrofolate reductase mutation is one of the ways that you can potentially develop hyperhomocystinemia. It is not the only way, and it is not it is not at all uncommon for you to have people who have this mutation, particularly heterozygotes, who don't have abnormalities in homocysteine and are frankly not at markedly increased thrombotic risk. I classify the lupus anticoagulant as a vascular disorder just because the antiphospholipid syndrome is in many ways sort of a vasculitis, and because some vasculitic disorders and collagen vascular diseases can manifest themselves by a lupus-like anticoagulant, which of course is named because it prolongs the PT or PTT, usually the PTT, and not because it actually causes the patient to be anticoagulated. It causes them to be hyperthrombotic, frankly. There are disorders of cellular activation, which are primarily the myeloproliferative disorders. These are thrombophilic states. They're the major cause of death for the ones that have the JAK2 V617F mutation is thrombosis. But they're not routine. Other rare disorders are disorders of fibrinogen and plasminogen. These manifest themselves through impairing the breakdown of clots once formed. I won't talk too much about those, although I will talk a little about them. I really won't talk much at all about circumstances that kind of give you an increased general procoagulant environment, such as inflammation, which in and of itself is a hypercoagulable state, and markedly increased factor VIII. Marked increase in factor VIII is an interesting thrombophilic condition. Certainly there is a good statistical association between people whose factor VIII levels are greater than, say, 200%. Normal is 100%. So there's a strong statistical association. It's not entirely clear whether that's the cause of things or whether that is an epiphenomenon of some other process, like, for example, inflammation or vascular diseases. But in any event, I'm going to talk mostly about the ones that were on the first slide. So, choosing wisely number 2, I referred to earlier. And what it states is don't test for thrombophilia in adult patients with venous thromboembolism occurring in the setting of major transient risk factors. Now, the important point to remember here is that the major transient risk factors referred to are specific major transient risk factors. They are surgery, the post-op state, trauma, and prolonged immobility. There are other transient risk factors where, in fact, thrombophilia testing can be appropriate. And we'll talk about those in a minute. Why shouldn't you test? Well, this is again straight out of the Choosing Wisely document. Thrombophilia testing it's costly. It's not gigantically costly, but it is, $1,000 to $2,000 in charges to the patients, most labs, depending on how wild you get. It may result in harm if the duration of anticoagulation is inappropriate, prolonged, or if the patients are incorrectly labeled as thrombophilic. One question is going to be, if you have had a clot, how thrombophilic are you? And that depends a lot on the circumstances, and we'll show you some data. The other point that they make, and this will relate to Choosing Wisely number 6, which will pop up a few slides down, Thrombophilia testing does not change the management of venous thromboembolic events that occur in the setting of these specific major transient risk factors. So what's some of the data? There are a lot of studies out on this looking at large populations, and there are a lot of guidelines, and I'll cite a number of them. One of the challenges is that not all of them define major transient risk factors in the same way. And one of the problems is that a number of the studies, particularly the ones done perhaps 10 to 15 years ago, and even some more recently than that, have lumped pregnancy, hormonal replacement, or hormone-based contraception in as a transient risk factor. And as we're going to see in a few minutes, those are entirely different animals in the risk factor business. So this is the first one is a small study from the Lancet looking at the recurrence rate at 2 years, and people who had a thrombotic event caused by, associated with the post-op state. At 2 years in this particular study, and this is the only one that I've ever seen this low, didn't have any recurrent thrombosis. For people who had an unprovoked clot, they had about a 19.4% increase of recurrence in rate at 2 years. Now, in the next bullet point is a larger study looking at a substantial number of patients with cumulative occurrence of thrombotic events over 10 years following the first clot. And in this system, in the post-op, where they had post-op and trauma together, they had about 11% cumulative recurrence over 10 years. Idiopathic, however, was about 5 times as much. So obviously, being in the post-op or trauma state puts you in a substantially better recurrence mode than if you are in an idiopathic state. So what do guidelines say? Pretty much all the guidelines say that for trauma, the post-op state, or prolonged immobilization associated with a thromboembolic event, you do not do thrombophilic testing. And here are just 2 guidelines I've associated with. Both are European. The first is the National Institute for Clinical Effectiveness Guidelines, which is a European, British/European Union based system based out of England. And the other is a long-standing and relatively conservative group, the British Committee for Standards in Hematology. And both, along with lots of other guidelines, do not recommend thrombophilia testing for these 3 specific circumstances resulting in a thrombotic event. However, I do need to point out that an issue to bear in mind, it's not so much important in the thrombophilia testing question, but it is very important in the therapy question, is that, of course, these things do have to be transient. You are not, now, of course, we don't have non-transient, hopefully we're not having non-transient trauma, and hopefully you're not having a non-transient post-op state, but you can, in fact, have, you can have extremely prolonged immobilization. So the other point that showed up in the Choosing Wisely guidelines, and this again is a quote from it, when the event occurs in the setting of pregnancy or hormonal therapy, or when there is a strong family history in complicating a major transient risk factor, and I need to say also, when there is a strong family history, period. The role of thrombophilia testing is complex, and they recommend that you seek guidance, and guidance is what you're about to get. So what's the data on pregnancy and hormonal therapy being different provocations compared to other transient things like surgery and trauma? Again, if you go back to that study which looked at the cumulative recurrence over 10 years, you see again about 11% for post-op and trauma, about twice as much for pregnancy after 10 years. The British Committee guidelines suggests you would consider testing in pregnancy and contraception or hormone therapy unless you had already taken action based on family history by itself. And what does that mean? Well, if you have a first-degree relative who has had either a PE or a DVT, that increases your risk of having a PE or a DVT. If you have only one first-degree relative, and at any unselected relative, any age at the time of the thromboembolic event, your risk is roughly twice that of a person who does not have such a relative. If that relative is less than 50, which is somewhat increases the probability of some of the more high-risk thromboembolic events, thrombophilic abnormalities, then it goes up just a little bit. But if you have two or more first-degree relatives who have had a DVT or a PE, then that alone makes your risk almost 4 times that of someone who doesn't have such a relative. Now, the absolute risks are still pretty small, but when I show you some of the data of, for example, recurrence risk with known thrombophilic defects, this number is actually solidly in the middle. So if you have two relatives, two first-degree relatives who have had a thromboembolic event, you are at least moderate risk for having one yourself. And it would not be at all unreasonable to provide prophylaxis for a high-risk situation, something like surgery, something like prolonged immobilization, something like pregnancy, something like starting hormonal therapy, just on the basis of your family history alone, without any thrombophilic testing. Now, let me jump a little bit into therapy. Choosing wisely, item number 6, is to not treat with an anticoagulant for more than 3 months in a patient with the event associated in the setting of a major transient risk factor. Again, that also implies that the transient risk factor has gone away. If you are immobilized, you have a thrombotic event, one would be cautious after discontinuing it if you're still immobilized, although you might perhaps look at, under certain circumstances, switching from full therapeutic anticoagulation to, for example, prophylactic anticoagulation after 3 months. So what is the data? Well, somewhat against this point is the well-established data demonstrating, and this is just one study that demonstrates it, that a shorter duration of anticoagulation is actually a predictor of recurrence. The longer you stay anticoagulated, the less likely you are to have another clot, which does seem to make some sense. However, the guidelines are very consistent, and I cite here the American College of Chest Physicians guidelines just published in January about sticking to the 3-month period of treatment particularly if you've resolved the issue that led to it. And again, the key factors you need to be sure the risk factor was indeed transient, and things that you can look at as a way of assessing that the risk was perhaps transient is whether, for example, the D-dimer has become normal again, or whether there's evidence of clot resolution on ultrasound. If you have both, if this has actually been studied more at 6 months than at 3 months, but if the D-dimer has returned to normal, the risk of discontinuing anticoagulation leading to short-term recurrence is certainly relatively low. If the D-dimer remains elevated, the risk of recurrence after discontinuation in an unprovoked clotting event, at least, is fairly high. And we tend to extend these things. And if you have resolved your clot and don't have persistent clot, then that would be a strong supporter for discontinuing your anticoagulation. So, shifting just a little bit, why would you screen for thrombophilia in the first place? The two traditional reasons are that if you have a thrombophilic disorder, you would extend the period of anticoagulation to prevent recurrence. And the other thing is that you would counsel the patient's relatives so that they could avoid having a blood clot. Now, there are a fairly large number of studies, and 2 of them are cited here, and they're not immediately recent because it's generally considered a fairly established point that in general, if you look at a population of people who've had a thrombotic event and you compare the recurrence rate between the people who were tested for thrombophilia and the people who were not tested for thrombophilia, there's really no difference in the recurrence rate. So at kind of a population level, thrombophilia testing does not reduce the risk of recurrent thrombosis. Furthermore, if a patient has had 2 separate unprovoked events, then they are thrombophilic or hypercoagulable by definition, and they need indefinite anticoagulation, and indefinite anticoagulation is mostly life being indefinite itself. That's kind of, any coagulation until the risk of anticoagulation becomes too high to make it worthwhile. So if you had, let's just say somebody's an orphan and they don't have any family, and they have 2 separate unprovoked thrombotic events, that person needs to stay on anticoagulation. And I don't. If I wanted to go into the relative merits of different anticoagulants, this would be a whole afternoon long talk, and not very interesting, frankly. But if that person, that orphan, has 2 events, you don't need to do any testing. That person is at high risk for recurrence. They need to be on anticoagulation indefinitely. Yes?
If the patient has a DVT and a simultaneous PE, is that still classified as one event, or would that be 2?
That would probably be one event. You have to, it's usually separate over time. On the other hand, if they had a DVT in their right leg and in their left leg, that would be 2 events. If they had one really big one that was shaped like a Y, upside down Y, through the IVC and down both legs, that's probably one event, but it's one really bad event. And we might think that wouldn't necessarily make you hypercoagulable, but it ought to make somebody nervous. Okay, so what is the risk of recurrence if you have a known thrombophilic disorder? So this is data from the American Society of Hematology Education program a couple of years back. And if you're AT3 deficient, it's 5 to 10-fold compared to people who have had a thrombotic event and don't have a known thrombophilic state. Bit less with protein C deficiency, bit less with protein S in the same kind of range, expands. Protein S is a little harder to diagnose in many cases, and in some of the older studies, not all of the protein S's were caught. Factor V Leiden, 3 to 5-fold, prothrombin mutation, 2 to 3-fold. So these are somewhat lower risk things. So what's your status for having a thrombotic event if you are the relative of one of these folks? And it's not so much if you're asymptomatic relative. 1.5% for the big ones, 1.5% incidence of clot per year. For if you're a factor V Leiden homozygote, 1.8%. The other one's about 0.5% a year. Again, it's significant compared to just ambulatory friendly person strolling around the street, but it's not gigantic. So a relative, except under the circumstances that we talked about earlier, we've got multiple relatives, and this is not all first-degree relatives. It's not that huge. So what about asymptomatic relatives? If you have somebody who has a thrombophilic disorder, or you have somebody who has family members who have had a DVT, what should you do about it? It has not been an uncommon event over the years for people to come to me and say, my sister had a DVT, I want to be tested to see if I have a thrombophilic disorder. And I'd say, well, does your sister have a thrombophilic disorder? And they'll say, well, I don't know, we don't talk to each other. But they might not know. They just say, look, I've got clots in the family. I want to be tested. In general, If you have somebody who has a known defect, these guidelines, and these are the two I mentioned earlier, this one, say, just came out, they don't support testing of asymptomatic relatives of people who have even known defects. There are, however, in general, a couple of exceptions. Well, there's actually one exception, and then there's a variant on it. So if you have a female first-degree relative of one of these folks, so, it is the sister, for example, and that relative is contemplating pregnancy, hormonal contraception, or hormone replacement therapy, then it is certainly not wrong to test them, because there might be some steps that you would there might be some action you would take. What action would you take if they were pregnant and they had a known thrombophilia disorder? There is a little bit of debate, but depending on the high-risk defect, if you had a high-risk defect, you would absolutely put them on prophylactic anticoagulation during pregnancy and for about at least 6 to 12 weeks afterwards. You would certainly do that. You would discourage them from taking hormonal contraception, although there is some data recently out saying that hormonal contraception, hormone replacement in an unselected population is not associated with increased incidence of DVT in relatives of people with known defects, and in people with defects themselves, it is. Now, if you have a low-risk defect, the most common of which is being, say, a factor V Leiden or a prothrombin mutation heterozygote, it is generally not felt that testing is indicated even for the first-degree female relatives, but it is done fairly commonly. And it's done sort of as an extension of this thing, because they forget about the high-risk defect thing. And again, I also point out that if you've got two first-degree relatives, you are up in the same range as if you were a homozygote for factor V Leiden. So that in and of itself may be sufficient to guide your practices. So if you were going to test for thrombophilia, when would you do it? This has been a subject of significant debate over the years. One thought is that you should do it right at the very beginning when they show up in the emergency room or in your office or whatever. And the rationale is, well, they're not on anticoagulation yet. And, and later on they'll probably be in some kind of situation where you won't be able to get an accurate measurement because they're on Coumadin or something like that. Now, there is something to be said for that from a practicality standpoint. However, here's the problems are, first, particularly if you have a hefty thrombosis, things like protein C and protein S are falsely abnormal in that circumstance. Because they're measured as, well, protein S is measured antigenically, protein C is measured as an activity level. Antithrombin 3, if you're on it, is affected somewhat by an acute clot, but if you get put on heparin, it can be affected also. The problem is that it is not necessarily affected. So you can't be 100% sure what your result would mean. The testing for factor V Leiden or prothrombin mutation, you can do that anytime because it's a gene mutation. It's not affected by your state of anticoagulation. But so the other issue with doing it at the presenting, say, in the emergency room, is that, in fact, it adds a cost to the hospital stay, to the charge for the hospital stay, which is not reimbursed. Your reimbursement for an admission, for example, for a DVT or a PE is not increased by the fact that you spend an extra couple $1,000s on thrombophilic testing. So there's both a physiologic and an economic reason potentially not to do it. So the next question that you need to be asking yourself when you're thinking about your testing strategy is this a high-risk patient? The traditional criteria for being a high-risk thrombophilic patient are family history, particularly first-degree relatives, and being less than 50. If you're 90 years old and you show up with a PE or a DVT, and you order thrombophilia testing, certainly the patient needs Dopplers and things like that, and you need your head examined, because it's the likelihood that they have any significant hereditary factor is quite low if it's not presenting until they're 90. And the other thing that is not as strong, but a lot of people put weight on it, is if you have a catastrophic thrombosis. So if you have, if you thrombose your entire IVC, for example, which I've seen once or twice, and I don't frankly remember whether they were thrombophilic or not. I think one of them was and one of them wasn't. But in any event, so that is sometimes considered a high-risk situation. So you decide, okay, I'm going to test this patient. What do you test? What are you going to do? On all patients, you decide to test. You need to send off the factor V Leiden mutation, the prothrombin mutation, and then moving into things that are not necessary. Well, plasma homocysteine may be elevated as a result of a hereditary mutation. However, what actually makes you thrombophilic is not, for example, the fact that you have the methyl tetrahydrofolate reductase mutation. It is the fact that your homocysteine is elevated. So if your homocysteine is normal, the methyl tetrahydrofolate reductase mutation is of modest, if any, significance. And the other thing is, as a common acquired thing, would be to test for a lupus anticoagulant. The way I test for a lupus anticoagulant is with a functional assay, which is usually a partial thromboplastin time done under circumstances when there's reduced phospholipid, so that the antiphospholipid antibody is more likely to have its effect on the reaction and give you a prolonged result. And I send off for anticardiolipins, and usually, particularly if I think there's some kind of underlying vasculitis, I send off for anti-beta glycoprotein and anti-beta 2 glycoprotein 1 antibodies, which are highly specific, which is an antiphospholipid antibody, highly specific for association with thrombosis. Now, if you had all three of these abnormal, that is a problem. That is what we call in the trade a triple positive, and that is kind of a bad thing. And you might be a little aggressive about how you're going to anticoagulate that and how you would attack that particular issue. If you have a high-risk patient, then you would add functional assays for antithrombin 3 and protein C, and you would send off a free protein S antigen assay. Now, most of the time, your protein S comes as a set with total and free protein S. Nothing much you can do about that. They're probably going to run it that way, whether you order just the free or not. And the other thing is that because these assays are a little bit technically challenging, if you get an abnormal result, you should repeat it before you make a therapeutic decision on the basis of that. What's the timing? Oh, sorry, some more things here. Now, wait a minute, let me back up a little bit on this part of timing. So back to the timing. So you don't do it, if you don't do it at the beginning, when are you going to do it? You need to anticoagulate the patient for at least 3 months, and hopefully they're okay by then. And the recommendation nowadays is that if you feel on clinical factors that it is safe to discontinue anticoagulation at that point, or to consider discontinuing anticoagulation at that point, then you would wait 2 to 4 weeks, and if you're going to do testing, test them. And then if your circumstance were one where you would resume anticoagulation, go ahead and resume it. If it's one where you would just continue to observe them, which is going to be the case most of the time, then you would continue to observe them. Now, when I say at least 3 months, so let's say you had an unprovoked DVT. So you're a little bit of a higher risk situation than just a post-op state. What you would do is base it on clinical improvement. I myself, in spite of this, generally go about 6 months on unprovoked ones, and that's not an unreasonable thing to do. And at that point, I generally check a D-dimer, and if I had a reliable ultrasound venous ultrasound showing the clot, then I would repeat that to make sure it had cleared. And then if that has cleared, then I would consider taking them off. I might consider taking them off sooner if there were some kind of risk factor, if they were at increased risk for bleeding. For example, they have active ulcer disease and they have no evidence of extending clot. I might leave them on longer if they had significant evidence of persistent clot. So you identify the point at which you would think about taking them off. You take them off, and then a couple weeks later, you test them. And then, depending on the results of the testing, you might move forward. So, anyway, back to other things. So, and I apologize for getting distracted there. If you had a patient who had a thrombosis, and they have an elevated white count, an elevated platelet count, and/or an elevated platelet count, and/or an elevated hematocrit, and/or splenomegaly, or they had splanchnic vein thrombosis, those are things that make you think of myeloproliferative disorders. And you could consider sending off JAK2 mutation testing to see if they have a myeloproliferative disorder which is associated with hypercoagulable situations. The ones that are primarily associated with that are polycythemia vera, which is number one, and where thrombosis is the main cause of death. Essential thrombocythemia, which has a somewhat lower risk of thrombosis, but it's certainly significant. Myelofibrosis, a lot less. That's actually more likely to evolve to some kind of pancytopenic states. So anyway, those are things you would test consider testing in this particular circumstance. Now, if you had all the hereditary tests negative, lupus anticoagulant and homocysteine negative, but you had a positive family history, you might consider testing for dysfibrinogenemia. And the way to do that would be a thrombin clot time, because what you're looking at is an abnormal level of stability of the thrombin clot. And so even though you would think that that if you're hypercoagulable, your thrombin clot time should be normal, and just because your clot just stays, it can actually be abnormal whether you have a bleeding dysfibrinogenemia or a clotting dysfibrinogenemia. You would then confirm it by looking at the paired relationship between fibrinogen activity and fibrinogen antigen assays. And you usually need, you always need to send that out to a reference lab unless you're working at a place that can do the fibrinogen antigen in-house, because they have to be paired and concurrent. You can't use the routine fibrinogen, which is the clottable fibrinogen that we have here as a marker of it. I have tested a lot of people for this, and so far I've only found one who actually had a dysfibrinogenemia resulting in a thrombotic event. Plasminogen defect studies are much more rarely indicated. The circumstance would be similar to the dysfibrinogenemia, but you would probably need a much stronger family history. They're challenging because you actually have to draw the blood in a variety of difficult ways. So, for example, for some of these things, you have to draw the blood, for example, without a tourniquet, because putting a tourniquet on the patient's arm alters the result. So frankly, I'm not sure how, who gets many of these things. When I was a fellow, I used to get plucked a lot to be the normal control in these kind of things because I had big veins that people could see in those days. But anyway, so what do you do with the results? What don't you do is you don't take an asymptomatic relative who's never had a clot and put them on therapeutic anticoagulation. If that person is going into a high-risk setting, for example, they're going to have surgery, they're pregnant, they want to go on hormonal, supplementation or contraception, and they don't, and you can't talk them out of it, then you might consider a prophylactic dosing, but not full therapeutic anticoagulation. So if you had someone who has had a DVT and they have high-risk mutations, antithrombin 3, protein C, or protein S, and a lot would say factor V Leiden homozygosity, then you would consider, in the scenario I outlined for you, potentially putting them back on anticoagulation if their risk of bleeding is low, and leaving them on it for a prolonged period of time, basically until their risk of bleeding starts to act up. If you have people who have lower risk things, factor V Leiden heterozygotes, prothrombin mutation, there's some debate about whether a compound heterozygote for factor V Leiden and prothrombin mutation is a high risk or a low risk. Then I would just give them prophylaxis for a high risk situation and go from there. Now, if you identify hyperhomocystinemia, then you'd give them folate, B12, sometimes B6, and you would think about whether their clinical circumstance requires that they be on anticoagulation until you can see if you can get their homocysteine back down again. If you can get their homocysteine back down and keep it down, and usually if I were going to look at something like that, I would want to see a normal value, continue treatment, and see another normal value in 6 weeks. If I saw that, I actually, assuming they hadn't had 2 clots, and maybe sometimes even then, you would say, okay, this was a transient risk factor, and I have made it go away. And so when they are at a point when you would, on the basis of their clinical assessment, think about stopping anticoagulation, then you could do it. But I'd sure continue the folate and the B12 and B6 if you did it. If you have a patient with a lupus anticoagulant, you would consider treating the underlying disease, and particularly if they're triple positive, you might just look at immunosuppression with a variety of things, usually prednisone at least, and sometimes either Imuran, which is azathioprine, or cyclophosphamide to suppress it, particularly if they had had a significant clot, to try see if you can get that gone. If you can make the lupus anticoagulant go away, then again, if you can make it stay away for 6 weeks, then you could think about taking them off anticoagulation. Triple positives, you can almost never get it to go away. Any event, so would you, and you would again continue the anticoagulation while it is clinically indicated, while these particular potentially adjustable risk factors occur. I think that's my last slide, and so I'll take any questions for the last few minutes. Questions? Yes?
So for family history, does it matter if that relative develops unprovoked surgery?
That's an arguable question. If it's unprovoked, then obviously that matters a lot. If it's provoked, it matters somewhat, but not quite as much. It's certainly not as strong. The data I'm showing you is, I believe, for provoked clots, for unprovoked clots. So if a relative who's had a clot, like after an accident or surgery, is not the same as not having a relative who didn't have a clot, but it's not the same as a relative who had an unprovoked clot. So it's somewhere in the middle. Yes?
If the patient had DVT, was on 3 months of anticoagulation, had a D-dimer, ultrasound which was negative, stopped anticoagulation, 3 weeks later the patient has a neck surgery, and a week after that presents with a huge, massive saddle of PE.
Okay.
Is that the second one considered as a provoked or as an unprovoked event?
Okay. So, well, it would. What was the first one? Was it provoked or unprovoked? Okay.
63-year-old male.
Okay. So let me say that if you had that, I probably would not send a person into surgery without prophylaxis if they were 3 months after an unprovoked clot. I probably wouldn't do it if it was after 3 months after a provoked clot. So that was a person who you could argue was at increased risk just because of timing, and should have been covered because they were being put into a circumstance of stress. The answer is that I think most people would probably consider that, one unprovoked, one provoked shortly thereafter. I think a lot of people, and probably me also, would consider that an indication for indefinite anticoagulation.
And when do you work on these guys for any kind of heritable?
Well, again, like I talked about, if it would make a difference, if it's going to make, if you're going to leave the person on lifelong anticoagulation, well, so that would be a circumstance where you would certainly want to see everything resolved, and where there actually would be some risk. Now, the fact that the person had the clot at 3 weeks was likely related to the stress of surgery. That would be a difficult one to figure out when you could take them off, and so that would be just one of these challenging issues in medicine, and something would depend on what you would do in terms of their relatives. Would you just say, like in terms of their son, the 63-year-old man you said, in terms of sons and daughters, brothers and sisters, say, daddy had two blood clots, therefore I need to be prophylaxed in high risk situations. That might be the best way to handle it.
In these thrombo events were associated with active cancer, it's provoked, but we don't really.
Yeah, no, that's why cancer wasn't on the list, and I didn't speak about that one because that's a lecture in and of itself. In general, if you have a thrombotic event in the context of cancer, most people would go for indefinite anticoagulation, and most people would use low molecular weight heparin, probably Fragmin of the, but again, I'm not, that is the one that's kind of trendy, right? Fondaparinux, that's the one that's trendy right now. I don't know that any of the other ones are much worse, but that's, that is what most people would do. Some would argue that even in that circumstance you need to see a second clot, but usually in the setting of cancer, particularly if the patient is either in a hospice setting or is on active treatment, so the two extremes, then that would be. Then I think most people would anticoagulate while that went along. If you had got somebody into a remission and they were in a sustained remission, then I think that would be a circumstance where you might consider discontinuing it. Okay. I'm sorry, there's some little noise over this direction. Could you speak a little bit louder?
Yeah, the question is, the thrombosis at the unusual sites, like pulmonary embolism without deep vein thrombosis, rectal vein thrombosis, or cerebral venous line thrombosis, are they always an indication to do all these systemic testing like protein C, protein S? Should we always go on
So if you're asking about unusual sites, whether that alters the testing thing, PE without an identifiable DVT, I don't actually consider that all that unusual. A lot of the time, sometimes you know where the DVT is. It's in the lung now. It just broke loose and moved up. That is, some of the other ones. There's actually there is some debate about that. A lot of people would do thrombophilia testing on unusual sites. I don't think there's enough data from the guidelines to shape that. Yes.
I know your talk didn't touch on this, but what about arterial clots?
Okay, on arterial clots, there's a substantial debate in the field, which is why my talk didn't touch on it, as to whether virtually, pretty much all of the things that I showed you are associated, have their strongest association with venous clotting and not with arterial clotting. A number of the guidelines, and again, it's a complex question, and I didn't want to go into it. A number of the guidelines don't recommend hereditary thrombophilia testing in arterial thrombosis. Now, if I were seeing somebody with arterial thrombosis and I were inclined to do some testing, which I might be, the things that I would look for a lupus anticoagulant, which is associated on occasion with arterial thrombosis, and I would look for hyperhomocystinemia, which is associated with arterial thrombosis. So the other ones are almost exclusively venous issues. Now, one of the challenging things is when somebody who has, somebody comes in, somebody has an MI, and I've had this show up in my practice a couple of times over the years. Somebody has an MI, and somebody sends off a lot of thrombophilic things, and they find out that the person's got factor V Leiden. It's probably a coincidence, but that is also the sort of person that you're going to have all the relatives show up with either wanting their factor V Leiden results or with their factor V Leiden results in their hands and wanting you to anticoagulate them all to keep them from getting heart attacks. And I would say that in circumstances like that, aspirin is a nice medicine. Many folks, aspirin, as a form of anticoagulation for venous events, aspirin is statistically significantly better than nothing. It's not as good as therapeutic anticoagulation, but it is not, it can be helpful as someone who is at low risk physiologically, but perceives themselves as at high risk psychologically. And that is a possibility also. And it does have some, you can demonstrate in studies, it does reduce the risk of venous thrombosis. Yes.
So there's a confusion about pregnancy being provoked or unprovoked.
Yeah, pregnancy does not count as provoked in the sense of the guidelines for the 3 months.
What about any study showing the first half of pregnancy or the first trimester being less? And we saw the study saying the pregnancy itself is a high risk of.
Yes. So again, there hasn't been a huge. There are differences between early pregnancy and late pregnancy thrombosis. Early pregnancy is a little bit more, is probably a little more resembling of unprovoked than the later pregnancy is. Later, for example, DVTs in pregnancy tend to have a disproportionate relationship to the left leg because just like all young people being liberal, the baby leans to the left and squashes mom's IVC on that side more than they squash it on the right side. And so, there is, for example, a disproportionate representative of left leg DVTs in late pregnancy. That being said, they are, they are certain, pregnancy is not it does not classify as a classic provoked is a sufficient explanation, and so you would consider doing some testing in pregnancy. I generally do testing postpartum, for postpartum DVTs.
How about somebody with early pregnancy, DVT, with no history of such things in the last 2 pregnancies, and now this 3rd pregnancy end up with a catastrophic?
Yes. So again, one of the challenges of the thrombotic line of work is that it generally takes multiple hits, to do something, and you don't know, why something would happen one time and not happen the other times, and it would. So, the answer is I would probably do again, clotting in pregnancy is not the same as clotting after being immobile. And it is very reasonable to consider doing thrombophilia testing. If somebody had a catastrophic clot, I would certainly do testing. What I would do is I would anticoagulate them for probably 6 months or so afterwards, and then I would stop it and anticoagulate them and see where we stood. If their D-dimer were still elevated, I would continue the anticoagulation until it wasn't, and then I'd test them. Thank you.